In the past 2 weeks, we've been having a few neonates coming presenting with a centrally cyanosis secondary to a cardiac lesion. So I thought I must take this opportunity to do an approach to a centrally cyanosed neonate, both at birth and around day 2 to 3 of life. We'll be alternating between the two cases that we currently had in the unit. Please do make sure you stay with me till the end, and I hope you get to enjoy this. Welcome to Pete's Crib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. The first case is a day 1 late preterm very low birth weight, small for gestational age baby with a birth weight of 1.2 kgs at 35 weeks corrected gestational age, who was born via cesarean section for fetal distress. At birth, the neonate was in respiratory distress and deeply centrally cyanosed. On further cardiac examination, he had an ejection systolic murmur in the left upper sternal border. He had some signs of cardiac failure as evidenced by tachycardia, tachypnea, and hepatomegaly. An assessment of a cyanotic congenital heart disease in cardiac failure was made. The neonate was also assessed as a possible HMD since he was a preterm baby. Surfactant was given to this neonate and was put on CPAP, and also prostin was started. An echo that was done at birth did confirm a cyanotic congenital heart disease. The second case, it is a day 2 to 3 term baby who was born NVD, uneventful delivery. The baby was discharged to mom to the postnatal ward after birth. Then on day 3 of life, this neonate was found to be deeply centrally cyanosed, but the baby was not in respiratory distress. And the neonate was taken into the neonatal unit. On cardiac examination, this neonate was also found to have an ejection systolic murmur in the left upper sternal border. There were no signs of respiratory distress and there were no signs of cardiac failure. This neonate was also started on prostin and ventilated in NICU, and an echo was done, which also confirmed a severe congenital cyanotic heart disease. So central cyanosis in a neonate usually indicates a serious underlying pathology, and therefore it needs rapid assessment, rapid diagnosis, and therefore rapid management. It is important that when you are in doubt of what you are dealing with, you actually treat the neonate for the most critical conditions. So if you're looking at those causes of central cyanosis, you can realize that there's different causes starting from hypoventilatory disorders like airway abnormalities. So meaning that when you're doing your assessment of this neonate, it's important to start with the airway. So do ABC and make sure, because this is a neonate, they don't have congenital airway problems. For example, our second case, the term neonate, who had an ejection systolic murmur and was cyanosed and not in respiratory distress. He also had bilateral choanal stenosis, but it means that choanal stenosis was not that severe to give this neonate a respiratory distress, because if it was bad, he was supposed to be born in respiratory distress. So he didn't have much signs of respiratory distress, but mainly had cyanosis. So it's important to do your ABC, assess them from A downwards to exclude other congenital causes. So other causes, you can have your pulmonary causes like your pneumonias, anything that can cause ventilation perfusion mismatch or alveolar damage. You can have hematological problems like polycythemia can cause can make a patient to be centrally cyanosed. And then most importantly, you have to think about your right to left shunt causes. This is where we think about cyanotic congenital heart diseases versus PPHN. So most of the time when we're seeing these neonates, we actually want to differentiate between these two, because these two actually become an emergency and treating them is a bit different, and both of them, they need echo diagnosis. So when you are in doubt of which one you might be dealing with, it's important to actually treat for both while you are waiting for the echo, so that when the echo comes and it says it's one other than the other, you just stop the other treatment treatment and continue instead of waiting, or instead of treating the wrong thing only to find out when the echo is done, the patient has another thing. So that's where we're going to go today, in how we're going to differentiate between a right to left shunt, probably caused by a cyanotic congenital heart disease, versus a right to left shunt, possible caused by a PPHN, which is persistent pulmonary hypertension of the newborn. But not forgetting the other differentials. The other important thing we need to keep is that when you're resuscitating this neonate, when you are bag mass ventilating and giving that oxygen, all the other differentials that we have just listed, like your hypoventilatory disorders, your pulmonary disorders, and your hematological disorders, the sets will actually improve when you give oxygen, especially 100% oxygen. It is when the sets are not improving while you are giving 100% oxygen that you will mainly think of right to left shunt, which is what was happening in our two patients. Sets didn't budge even though those patients were given 100% oxygen. They still remain as they were while the patient was on oxygen. Now, this is where you would think you are dealing with a right to left shunt. Now, I'm going to take you through how to differentiate between a right to left shunt caused by a cyanotic congenital heart disease and a right to left shunt caused by a persistent pulmonary hypertension of the newborn. Now, as you are seeing this centrally cyanosed patient, and you have the differentials that we've just discussed in mind. So as you are resuscitating, especially as you are giving 100% oxygen, you are actually excluding some of the differentials. For example, your hypoventilatory disorders, most of them, as you are giving 100% oxygen, bagging the baby, the FIO, the oxygen and the sets are supposed to actually increase. And also your polycythemias, the sets are supposed to increase when you are actually delivering 100% oxygen. So you get clues. If you're not getting the response that you're supposed to be getting, you get to exclude some of your differentials as the cause of this central cyanosis. If there is minimal or no change in your sets while you are giving this 100% oxygen during this resuscitation, then the only two close things that you get to be left with is whether you are dealing with a persistent pulmonary hypertension of the newborn, or you are dealing with a cardiac lesion, a cyanotic congenital cardiac lesion. So some of the clues that you need to get along the way to differentiate between these two is that even though certain cardiac conditions can also cause respiratory distress, but it is known that a cardiac problem usually gives a mild form of a respiratory distress, or this patient might not even be in respiratory distress. As you can see from our two cases, one baby was in respiratory distress, but the other one was not in respiratory distress. So they tend to be calmer in respiratory distress as opposed to a respiratory problem or a PPHN. So if you find this neonate in respiratory distress, then you might think maybe you might be dealing with a PPHN than you might be dealing with a cardiac problem. The other clue is to do differential sets. What do we mean by that? You do pre-ductal and post-ductal sets. And if the difference between the two is between 5 to 10%, you think more of a cardiac problem, of a cyanotic congenital heart problem. But if the difference between pre-ductal and post-ductal sets is more than 10 to 15%, then you will think you are dealing more of a persistent pulmonary hypertension of the newborn. So these are the clues that you can get clinically so that you get to act appropriately. You get to start prostin while you are waiting for the echo, or you get to start Magsalf while you are waiting, or whatever treatment of persistent pulmonary hypertension of the newborn you have in your unit. But if you are still in doubt after clinical examination, I would advise that you treat for both while you are waiting for the echo to be done. The other thing that most people tend to do is a hyperoxia test. Now, it is important for me to emphasize that a hyperoxia test doesn't really differentiate between PPHN and a cardiac lesion, because both of these conditions, they cause a right to left shunt. But a hyperoxia test, it gives you a clue as to whether you are dealing with a underlying pulmonary problem or a cardiac problem. It has nothing to do really with a PPHN or a cardiac lesion, because these two might act the same because both of them are right to left shunts. But you want to get a clue when you're doing a hyperoxia test as to whether you are dealing with an underlying pulmonary problem or an underlying cyanotic congenital heart problem. So what you would do is that you would have your baseline blood gas. So you would do your blood gas on room air and look at your baseline partial pressure of oxygen. And then after that, you would administer 100% oxygen on this patient for at least 10 or more minutes. Then after that, you repeat your blood gases. If your partial pressure of oxygen increases to more than 100 millimeters of mercury, or the sets increase by at least 15% after you've administered your oxygen, you are most likely dealing with a pulmonary disease problem. But if your partial pressure of oxygen remains less than 70 millimeters of mercury, or it rises only by less than 30 millimeters of mercury, or your sets remain unchanged after delivering 100% oxygen, then you are most likely dealing with a cyanotic congenital cardiac problem or with your PPHN. So this is important to keep. I hope it makes sense as we're moving forward with our cases. So both our two cases, we actually got the clues. As I've said, the first preterm baby was in respiratory distress and there was no improvement after administering oxygen. So it means in a way we excluded some of our differentials because we were supposed to get some form of improvement on our sets while administering the oxygen. So both these patients, after being administered 100% oxygen, there was very minimal change in their saturation. Even on giving surfactant and putting the preterm neonate on BiPAP, there was really any change. So that's what has made us to think maybe we are dealing with a PPHN or a cyanotic congenital heart disease. Hence, we needed an echo to make that proper diagnosis. Now, if after your clinical examination, you are suspecting more of a cyanotic congenital heart disease, it is important to know how to approach such patient, your approach to a cyanotic congenital heart disease. So the first thing is, are you dealing with a centrally cyanosed neonate with increased pulmonary blood flow, or are you dealing with a centrally cyanosed neonate with decreased pulmonary blood flow? What do we mean by that? So are you dealing with a centrally cyanosed neonate with signs of respiratory distress, meaning that this neonate is having increased pulmonary blood flow and therefore lung congestion, giving this neonate respiratory distress? And these type of neonates can also even have signs of cardiac failure, whereas the ones with a centrally cyanosed neonate with decreased pulmonary blood flow, because they don't have much perfusion going to the lungs, it means they will not be in respiratory distress and they will rarely go into cardiac failure. So that's what we mean by increased pulmonary blood flow and decreased pulmonary blood flow clinically. So meaning that it is important when you're dealing with a centrally cyanosed neonate to look for signs of respiratory distress, because if they are there, you might be dealing with a cardiac with increased pulmonary blood flow as opposed to a cardiac with decreased pulmonary blood flow. Let me take you back to our two patients. So the late preterm baby was centrally cyanosed and was in severe respiratory distress, whereas the term baby, even though he was centrally cyanosed, was actually not in respiratory distress. So it is important to keep this differentiation as you are clerking or admitting these patients, because your differentials are going to be different. For example, if you have a centrally cyanosed neonate with increased pulmonary blood flow, the differentials that you will be thinking about in that patient even before you actually start doing your cardiac examinations, it's things like a TGA, transposition of the great arteries, to truncus arteriosus, total anomalous pulmonary venous return. So those are the sum of the differentials that you will be thinking about. But when you are dealing with a centrally cyanosed neonate with decreased pulmonary blood flow, meaning that this neonate is not in respiratory distress clinically, then you are most likely dealing with things that will cause right outflow obstruction, meaning that there is no blood going to the lungs, and therefore lungs are not congested, hence the neonate is not in respiratory distress, and hence the neonate might not have signs of cardiac failure. Then in that case, you think about things like tetralogy of Fallot, you think things like critical pulmonary stenosis or pulmonary atresia, you think about things like tricuspid atresias. So that's how you approach this neonate. So even before the echo gets done, just by looking clinically at this neonate, you can actually have differentials. So the differentials we had for the term baby, because he was centrally cyanosed with no signs of respiratory distress, so we assumed he had decreased pulmonary blood flow. So we had tetralogy of Fallot as a differential. We had a critical PS or pulmonary critical PS or pulmonary atresia as a differential, and we had tricuspid atresia as a differential. Whereas in the preterm baby who was in respiratory distress, we had things like TGA, truncus, and total pulmonary anomalous venous return as a differential. So this is how you approach a child that you are suspecting is having a cyanotic congenital heart disease before you do an echo. The other aspect I wanted to draw your attention to is the timing of the cyanosis, especially on that term baby who was allegedly born uneventful. There were no problems. He was discharged to mom. And then on day 3 of life, that's when the cyanosis started appearing. So that is very important and significant because it is giving you a clue that you might be dealing with a duct-dependent lesion, because a PDA in a term neonates start fully closing around day 3 of life. So that was when they will actually present with a cyanotic cardiac problem if they were dependent on that PDA which was initially open. Then the minute it closes, that's when their problems will start. Just like in our term neonate, who was born uneventful, discharged to mom, and then on day 3 of life was found to actually be deeply cyanosed. It may actually happen that even at birth there was some form of cyanosis, but it was still not severe enough to actually be evident with the naked eye, because hence the child was discharged to mom. But now when the PDA closes, it becomes very significant and the baby starts presenting. So it means in such a baby, it is important that you consider starting the prostin very early, because that history and that timing is very significant of a duct-dependent lesion. Now, looking back to our approach to cyanotic congenital heart disease, where we said there's a side with increased pulmonary blood flow and decreased pulmonary blood flow. And we said the term baby was on the side of decreased pulmonary blood flow because he was not in respiratory distress and had no signs of cardiac failure. So all the differentials that we have given there, like the tetralogy of Fallot, critical PS, pulmonary atresia, tricuspid atresias, they are all duct-dependent lesions. So if you suspect that the patient, you have such differentials, it is important to start the patient on prostin immediately. Then out of the other side with increased pulmonary blood flow, looking at our preterm baby who was centrally cyanosed with signs of respiratory distress and in cardiac failure, where we had differentials like TGA, truncus, and total pulmonary anomalous venous return. Out of those 3, TGA is a duct-dependent lesion. So if you're suspecting that a patient might be having TGA, you have to also put the patient on prostin. So both these patients were put on prostin and echoes were done. And echoes, they confirmed that the preterm baby who was in cardiac failure and deeply cyanosed, he had a transposition of the great arteries, and the term neonate had a critical PS, hence he was not in respiratory distress, and hence he didn't have signs of cardiac failure. So that is how you would approach a cyanotic neonate, especially a cyanotic congenital heart disease. So you get clues on clinical examination before you do an echo. By the time you are doing an echo, you already have differentials that you want to prove or disprove. So you don't just diagnose with an echo when you have not even had a thought process. So your thought process is your approach to a cyanotic congenital heart disease, whether the neonate is in respiratory distress or not in respiratory distress, with signs of cardiac failure or with no signs of cardiac failure. So if you keep that approach, that will give you specific differentials. So when you're doing the echo, you are specifically looking for those differentials that you already thought about. I hope it makes sense. Please subscribe if you haven't already subscribed, and hit the bell notification so that you get updates whenever I'm uploading a new video.